So our next session is ABO and HLA incompatible transplants, understanding the essentials. And our speaker is Dr. Vinant Bhargava. He is a senior consultant nephrologist at Sir Gangaram Hospital, Delhi, an academic leader, a teacher for DNB students. He holds positions in the Indian Society of Nephrology, Indian Society of Organ Transplantation, and Delhi Nephrological Society. He has authored books and numerous national and international publications. So, Dr. Bhargava, over to you.
Thank you, ma'am. Thank you, Gupta sir, who's always been a sir to me since a very long time. And I can see here that we have a lot of audience here, and I've been told that you're all transplant. You are going to be doing all management of patients in pre-transplant time, and you're going to be preparing papers. So since I was told that we're running out of time, let me start with the questions first. So now I would want to ask the audience over here that what is the question that comes in your mind when you're looking at something called as an incompatible transplant? Is there anybody who can just tell me what is going on in your mind at that time? Incompatible transplant. Yes, that's very important. So that's what we think. It's ABO incompatible transplant. And what else can be incompatible? Yes, so that's called an HLA incompatible transplant. Anything else which is an incompatible? Yes, so that comes under the group or subgroup of HLA incompatible. And I think the most important thing here is the incompatible transplant from the point of view of family relations. So it's incompatible for any system to do transplant which is outside the family relation. And it becomes very difficult for transplant coordinators to ward off such patients and to make their attendants understand that such a transplant cannot take place. So
also the cost factor, Dr. Bhargava. It's costlier than a normal transplant.
That's right, that's right. So we'll come through all of this. I've been given about 30 minutes. What I'll try to do is I'll try to wrap it up in just about 10 minutes for you people, okay? And 20 minutes we can have question answers. Trust me for that. Okay, so we don't start with summary first, okay? So this just come up first. So just to tell you what transplantation is all about, we've been having a lot of talks since today morning, and I'm sure that you know it's one of the most preferred modality of renal replacement therapy for your patients, primarily because of the fact that it ensures that your patient lives around you for a longer period of time than when he's on dialysis. But we have a big problem in our country, is that the disease donor program is mostly not a very good program in most of the states in this country, and we've discussed about this at great length since today morning. And this is against the Western population, where you have a very good and a robust program in which you have the disease donor program running very well. We have, unfortunately, only live transplants. So there's an estimate that approximate from about 2.2 million individuals who require transplant, there are only about 7,500 kidney transplants. I'm sticking myself to kidney transplants because I'm a nephrologist. And you will be surprised to know that there are less than 300 centers in this country that perform some kind of transplant. And obviously the most important and the most commonly done transplant is the kidney transplant. And as we discussed, and as the intelligent audience has already alluded before, that these are the kind of incompatibilities that you can look at, the ABO incompatible transplant, which used to be actually a contraindication until about 2 decades back, where somebody just used their mind and thought that why should an incompatible transplant not be done? So in 2013, somebody in India realized that maybe we can do an ABO incompatible transplant and publish it. So publish it would means that it becomes literature, but you have ABO incompatible transplants that have been taken place in this country as early as about 2005 also, because of technology that we bought from the Western world, but we were not ready to share, and so we didn't actually have that kind of a database here to tell you that we started transplants in 2005. So in the recent years, the ability of the global transplant community to overcome the barrier of ABO incompatible transplants has actually increased many folds, and now we can accept just about any kind of patient, any kind of incompatibility, whether it's ABO incompatible, blood group incompatible, or maybe even HLA incompatible to do these transplants. So we are basically increasing our donor pool. So if you increase your donor pool, you will have more transplants, more survival of patients who have entered into end-stage renal disease or on dialysis. So what exactly is an ABO incompatible transplant? So we know that A, B, O, these are different group factors. These are the blood group factors. They are antigens basically. And they are expressed on red blood cells, lymphocytes, platelets, epithelial cells, as well as endothelial cells. So when you have a foreign antigen, you have an antibody against it. And that's what happens when you have a foreign antigen with a blood group factor B going into a patient who has a blood group factor A. So the A recognizes the B antigen as a foreign antigen and generates anti-B antibodies. So when you have to do such a transplant, you have the barrier of the HLA, which you have crossed, but you have not crossed the barrier of the blood group. So there have to be ways in which you can make such patients get accepted into the transplant program and ensure that the graft survives for a longer period of time. So antibodies to both A and B are found in an individual with B group, while an individual who has AB has no antibodies at all. So the AB is actually a universal acceptor and O is a universal donor. So now once you have identified your patient that, okay, this patient is incompatible to an ABO transplant, now what is your treatment goal? Is to lower the antibodies. So how much will you lower the antibodies? For example, if you have A and you have B, so you're looking at anti-B titers. If you have B as a recipient and A as a donor, you're looking at anti-A titers. So how much should you reduce before you go in for a transplant? Because that's the end point from where you start enrolling the patient into the surgical program where he gets the surgery done. There are two kinds of sub-antibodies in these antigens which are generated. One is the IgG and one is the IgM. It's very important to understand that IgG is the one that has a very long memory. So it's very relevant for clinical outcomes. So you need to have a very long memory when you're going into exam. And the short memory is also important, but the long memory is the one that makes you top, and the short memory is the one that makes you pass. So the short memory over here stands for M, IgM. So the IgM is a short memory, though it's essential. It's been demonstrated now in isolated case reports that you need to lower the IgM levels too, but it seems to be not very essential when you're enrolling patients in a transplant program. So as your titers are high, and once you have a high baseline titer from where you start, you can actually predict what your graft survival is going to be. So it doesn't mean that if you have a titer of 1:1052, the outcomes are going to be the same as somebody who has a titer of 1:16 when they start off. There is always going to be some amount of problem, though you will desensitize these patients and have therapies that we'll talk about later on and bring it down to 1:16, but both of these patients cohorts will have different outcomes. And there has been some data on that too, on 8-year graft survival. So the 1:16 is 79%, 1:32 to 1:64 is 66.8%, and as the titers go up, you will see that the graft survival rates are actually quite low. So it just dips down to just about 1/3 of your graft surviving at 8 years if you have a titer which is 1:128 or higher. But you can give such patients at least dialysis-free survival for the time that they've been transplanted. But however, the titers, the exact titer at which you should transplant has been evolving since a long period of time, and there seems to be a phenotypic variation and epigenetic variation all over the planet. For example, the Japanese cohort and the Japanese surgeons will accept patients even at a titer of 1:64 without any desensitization, and they will just go ahead and do the transplant, and they don't see too much of rejection. For us, we take it down to about 1:8, 1:16. So you see, the titers just keep on evolving depending on which part of the world you're staying in. The British Transplantation Society recommends a baseline titer of less than 1:8. Now look at what happens with Japan. They go up to 1:128, which is unthinkable when we are going to do a transplant here. But we are very stringent because we are very scared as a population. So we bring it down all the way to 1:8, even 1:4, less than 1:4. So, however, I think the consensus in the hall should be any titer between 1:4 to 1:16, depending on what the HLA sensitization of this patient is, should be acceptable to go ahead with an ABN compatible transplant. Now, these are the different protocols that have been used, which I will talk about later on, but I just wanted to tell you that how the variability has taken place. Countries like America, Germany, now, Germans have taken the titers all the way down as to 1:4. We have data which has been published with 1:32 with the different therapies, which I'll be talking about later on. So the desensitization protocol as such, what does it mean? That means you're going to remove the sensitizing factors with medical therapy, assisted therapy, and you're going to ensure that there are no antibodies by the time the graft is implanted into the recipient. So the selection is obviously decided by, as ma'am said, the cost is the most important thing in the country. You have to find a way in which you transplant your patients and also keep them alive financially for the next 10 years, not just to end it at the end of transplant by using very, very costly therapy. Then the baseline antibody titers, we've spoken about this. Most important thing is the complications. Now, the different therapies have different complications. So you have to, as a clinician, decide which therapy is going to be beneficial for your patient. There are two primary therapies. One is called as the immune adsorption. As the word says adsorption, it's going to just absorb the immune factors with a special cartridge, which is very expensive, available in the country in the cost of 2.5 to 3.5 lakhs. And then you have something called as the plasmapheresis, which is very commonly used in most of the centers, which is nearly 1/4 the cost of this therapy, but has more complications, which we'll discuss. Then about the availability. There are some centers where plasmapheresis is available, but immunoadsorption is not available, as columns are not available because they're expensive, they have to be imported from outside. So then that's one of the factors, and obviously the experience. There are centers which have never used immunoadsorption columns, and it's always prudent to tell your patient that you will be the first patient in which the immunoadsorption column is going to be used, and we don't know what the effect is going to be, though it's an expensive therapy. So with that, I'll bring you down to plasmapheresis. I think my 10 minutes are still not over. So the therapeutic plasmapheresis, though is widely available for antibody removal in ABO incompatible transplant, but you should individualize the therapy depending on the baseline titer. So you can actually decide on how many plasma exchanges can be given to a patient when you have the baseline titers of these patients, so that you can get the baseline titers to the lowest possible to your institutional protocols and go ahead with the transplant. Now this is just a small chart that I made, which I copied from one of the journals, and we also kind of use this, though we're not pragmatic on using this. You'll see as the titers are going high, that is from 32, that is 1:32, to 1:512. So these are titers which are combined titers, the IgG as well as the IgM, or either of the two, and IgG being more important as obviously. You'll see that the number of cycles have increased. But this is in the most acceptable form of therapies where you're going to replace the plasma, calculating the body weight, and are going to be very, very accurate on how much replacement you're going to give. So that is a big problem because standardization of plasmapheresis in dialysis units is a big problem. So you could end up doing 3 plasma exchanges, but ensure the titer to be falling equal to just about 1 plasma exchange. So that's one thing. So to overcome that, you have something called as a double filtration plasmapheresis, which is not available in most of the centers, but it's a very easy form of therapy in which if you have, like the word says, if you have plasmapheresis and you have something which is left over, you do a double filtration plasmapheresis so that you will ensure that your antibody removal is more efficient. So what does DFPP do? It removes the immunoglobulin fraction of the serum, and obviously it helps in minimizing the volume of substitution fluid, because there is always a limit to the amount of fluid that you can give to calculate the volume that goes inside and the volume that you remove. And you don't want your patients to have more volume going in and less volume coming out and giving them volume overload at the end of the session. What it basically does is that first the plasma is separated by a plasma separator, and in the second, the gamma globulins are then separated by a plasma fractionator. So the process will remove concentrated serum globulin fractions, including the antibodies, that's what you're looking at. And you know the advantage of DFPP is it's very selective in removal of immunoglobulins. It requires smaller volumes of substitution fluid, as we discussed before. There's better reduction of antibody titers. And you can see that you can have up to even 70% removal of the antibody titers, which doesn't happen with the plasma exchange. So this is just a small pictorial which I thought I will share with you, which very clearly tells us that there is, if you look here, there's a primary filter right on top over there. That is the primary filter. And then you have a secondary filter. This is just a very simple cartoon for what I had to explain. So you have the blood flowing in from the primary filter, and you'll see the plasma is getting separated out, and whatever is remaining left is then going into the secondary filter, and the waste comes out, which is actually the antibodies, and the remaining goes back into the patient. So this is the entire circuit of the dialysis machine, which has double pumps, 2 pumps together, and then they are just filtering in unison with each other. And in terms of replacement fluid, the replacement fluid that is used is crystalloid, which is normal saline or even ringer lactate in most of the centers. Albumin and crystalloids are recommended for both plasmapheresis and DFPP. Since in DFPP there is very less removal of albumin, so you don't actually need albumin, you can also give fresh frozen plasma, especially if you had at least more than 4 sessions of either plasmapheresis or DFPP, because all of this is also going to remove the blood clotting factors. And if you're going to do a transplant after 4 sessions of DFPP or plasma exchange, you'll have more risk of a bleeding disorder. So you can use FFP as, and what is important here is the FFP itself also has the blood group antigen. So you would want to use a donor blood group in this case to replace that as a plasma replacement. This is what I was talking to you about, the expensive therapy, which is called the immunoadsorption. So there's several columns which are available, Vitrosorb, Glycosorb, and there are other Adsopac, which is the Russian column. And they're very good actually in terms of removal of antibodies. They can suddenly just bring down the antibody titer, especially used in patients who have very high baseline titers, or patients who've undergone 2 or 3 sessions of plasma exchange. And we see in those patients, the titers are not coming down, the patient's getting very, very frustrated, and you can see that they're getting some complications of plasma exchange in the form of electrolyte imbalances or maybe bleeding disorders. So then you go ahead and use a column. And there are some centers who say, no, we don't want to use plasma exchange, we want to use only columns. So these are centers where you have very rich patients coming in, and they're already well read, and they say, okay, fine, immunoadsorption columns to be used. So this is just a comparison chart of the different protocols or different parameters that we do when we're looking at plasma exchange, DFPP, and immunoabsorption. Look at the efficiency here. You'll see very clearly that the efficiency is, this is the efficiency. You look at the efficiency is much better with immunoabsorption, though the availability of immunoabsorption columns are lesser. So for smaller centers, I think this is what you should stick to. In terms of effectiveness, obviously we know that immunoabsorption costs more. It's very specific, so you will have higher removal. And the number of sessions to reach target titers, it's important because we are talking about cost here. Now, the cost is not just the cost of the appliance that you're using, it's also the cost of keeping the patient away from transplant for the number of sessions that you. For example, if you're an immunoabsorption column, ensures that you can do the transplant in 5 days' time, and a plasma exchange ensures that you do a transplant in 20 days' time, you can imagine the cost of dialysis, the cost of medication that the patient is going to be, and obviously the cost of mental trauma that I can't undergo a transplant. So all that has to be taken into consideration. And about the removal of albumin, there is no removal of albumin as we spoke about in immunoadsorption. So your patients who are hypoalbuminemic, they might benefit with this. But however, all of our patients are hypoalbuminemic, and we still use plasma exchange and DFPP, and they do well. In terms of replacement fluid quantity, you don't need any replacement fluid in immunoadsorption because it's very simple. The blood goes in, the antibodies get stuck onto a particular membrane, onto different beads which are already coated with antigens, and that's the end of your antibodies. So when the blood goes back, there's no replacement of any fluid at all. You're just sending the blood into a chamber and purifying it of its antibodies and sending it back. In terms of cost, obviously we discuss, and reuse of plasma filters is possible, though in very specialized centers, and also immunoadsorption columns, though when you buy them, it says very clearly on the literature that it can't be reused, but we've got publications and we've used our immunoadsorption columns up to 3 reuses. So in terms of this molecule, it's called as the IVIG. So it's been used as a component of the avian compatible desensitization protocol. And however, it's an expensive therapy. What it basically does is it does immunomodulation. So it just binds onto the excess antibodies which are left after your plasma exchange has been taken place, because what basically plasma exchange does is it depletes you of your antibodies, but then they bounce back again from the intravascular and from the other cells back again. So IVIG takes care of that. But this is again very expensive. So some centers do it, some centers don't use it. Then you have as a rituximab, this is a monoclonal antibody, which is a very important component of all the desensitization protocols. This was basically invented for the first time for cancer disease, but now it's been used rampantly across different disorders in the nephrology community, and I think we are using it more than what the oncologists are using it now. And the doses are all dependent on what your institution protocol is, but the lower, the better. So that's available as 100 milligrams, 500 milligrams, so we'll just modulate it. It should ideally be given 2 weeks before you start your enrollment for plasma exchange, and or 2 weeks before the time that you have decided that this patient should undergo a transplant. Now these are the different protocols that we have spoken about. You can see over here that there are different protocols over here that have been used, and especially these two countries over here, that is the European Union, because they are the ones who invented these filters, that is the immunoabsorption columns. So they have been using it, and look at the titers that they generally get, and obviously their outcomes might be a little better as compared to others. So this is SGRH, which stands for Sir Gangaram Hospital. This is the protocol that we follow. I spoke to you about rituximab today, which was a monoclonal antibody. Look here, we're using it at day -14, which is 2 weeks before. And then we start a drug called as tacrolimus, which is an immunosuppressant. And we combine it with mycophenolate, which is another immunosuppressant. And we give it at half the dose as compared to the dose that you give after the transplantation. You do plasma exchanges till the time that you get your desired titers, 1:4 to 1:8. And then after that, you do the surgery, do the transplant, and increase the level of tacrolimus as well as the MMF, and add steroids along with that. So once you've done this, then the monitoring takes place. With that, I take you to just 2 or 3 slides on HLA desensitization, because this is something which is very important for us to understand. This HLA desensitization is the most difficult transplant to perform for the nephrologist, because these HLA antibodies are like leeches. They will not go away very easily, and if they do go away, they come back very easily. So all transplant candidates that have been exposed, that is all the dialysis patients, all the pre-dialysis patients who have been exposed to non-self antigens, especially via blood transfusions, because they're all anemic, they're all CKD patients, or who had pregnancies in the past. That's a very important cause of alloimmunization. And previous transplants, so they've had a previous transplant, so the graft itself was a source of generating a lot of antibodies, or even infections. Infections can cause antibody response. So all of these will develop some kind of an alloantibody to the HLA, and this is called as sensitization to the HLA. So the transplantation rates obviously are low, because it's so difficult to perform such a transplant and desensitize such patients, because most of these patients continue to stay positive in their cross-match. And so the method that is chosen for desensitization is generally mostly all guided by the phenotyping and the immunological workup of the HLA, and that is done by something called as a donor-specific antibody. So these are the things which are very important. These tests are very important if you are looking at the transplantation of sensitized patients, especially ABO incompatible or HLA incompatible. First is the CDC cross-match. I'm sure when your patients come to you, all of them have a CDC cross-match, and that's when they come to you, because the nephrologist has said, okay, fine, now he's the one with the negative CDC cross-match. Now imagine somebody comes to you with a positive CDC cross-match. So then what do? A flow cytometric cross-match, which is a different level of cross-match as compared. It has a different mechanism in which the cross-match is done. So they can be used complementary together, especially in patients whom you think are going to be sensitized. Then you have something called as a panel reactive antibodies. You would wonder why the panel reactive antibodies are done for most of these patients. It's to specify what the sensitization risk of this one person is to the community around. For example, if that patient has to be put into a disease donor program and you do a PRA and the PRA is high, so that means if the PRA is say about 80%, so that means he's sensitized to about 80% of the kidneys that could be allotted to him in the general population. He's going to be cross-match negative to just 20%. So that is what it tells you. And in terms of single antigen bead, which is a very, very sensitive test, which also gives you the calculated PRA and the virtual PRA, is very important when you're looking at these. So the conventional desensitization of these patients who are HLA sensitized also essentially is almost the same. Only thing here is that the low dose IVIG or a high dose IVIG can be used in these patients and should be used because these patients don't behave like ABN compatible transplants. So ABN compatible, they're easy to desensitize, but HLA are much tougher to desensitize. And here also you're looking at rituximab intermittently and other agents too. Now these are the different therapies. I don't want to bore you with all this because I said my 10 minutes, so it's just about 9 minutes now. These are some therapies like proteasome inhibitors. So we have a lot of things. That's what I want to boast to you about, that we have a lot of things in which we can give to our patients, with which we can make them all right. And with this, I would like to also conclude and say, and to summarize, that sensitized patients are challenging, but they are the need of, you have to have protocols set up for a good transplant unit. We know that we've spoken about modalities such as plasma exchange, double filtration plasmapheresis, immunoadsorption columns, rituximab, IVIG, and the graft survival rates are largely dependent on the pre-transplantation sensitization. So if you have a high baseline titer of either the blood group antigens or even the HLA antigens, your outcomes are not going to be very good as compared to the ones with the lower ones. So there are some artificial intelligence based tools which are now getting devised in which you can match the incompatible pairs, and you can have lower desensitization protocols because you can pick up now people from across the state who can match against each other even if they are HLA sensitized, but not sensitized to a donor from a different pool. And despite you increasing the overall immunosuppression, the risk of infections, that's the biggest concern that we have, that we are immunosuppressing these patients so much as compared to a conventional transplant. But surprisingly, the risk of infection in long term is not that high as compared to the other patients too. And it's very important to have a very good transplant immunology lab facility, because otherwise you'll not know when to stop your desensitization protocol. With that, I would like to thank you all, and thank you for your 10 minutes to me. And if there are any questions we can take, or maybe we are late.
So, any questions? We have one question because we have 1 minute left.
Sir, my question is related to HLA, and we had a patient, HLA, it was mother to daughter. So the mother was a donor. So HLA was fine, CDC was fine, PRA was positive, and we tested the DSA, it was also positive. So we refused her as a donor, and she went to the other hospital, and there she was accepted as a donor. So I'm not getting the thing why they accepted her as a donor.
Right. So I think the important thing to realize here is that presence of DSA itself is not a contraindication unless it's in a range which is going to be dangerous for us to do a desensitization protocol. Having said that, we don't have an upper limit to how much DSA is acceptable, how much lower DSA is totally acceptable. We don't have that. But I think the answer to your question is totally dependent on the nephrologist or the team that is responsible for doing the transplant and the kind of facilities that you have for desensitization. For example, if you don't have the expertise, like that was the last point of my consideration, whether you have the expertise or not, then you would want to refer it to a different center that can take it up. Generally, I think the first center that you mentioned has to be a government center, and the second center who took it up has to be a private center, from my understanding.
So our patient also went to your center.
Good one.
So that's about it, yeah.
Thank you, sir.
Thank you.
Thank you so much.
Thank you for sending your patients, sir.
Okay.
If there are some more who want to send some more, you can just take my number. Always available.
Thank you so much. Thank you, Dr. Bhargava, for a very nice, informative talk. So I would request Dr. Oswal again to felicitate, please. Dr. Vinant Bhargava.